All right, well, thanks everybody for joining us for this breakout session. I'm John Voorhees. I'm one of the pediatric orthopedists here at Stanford, and I'm doing this session today with Marie Hamilton and Andrea Johnson, who are two of our excellent wound care nurses. So we're going to be talking about physician and nursing best practices as they relate to orthopedic surgery and wound care. So we'll break up the session into two parts. So the first part, I'm going to give a brief overview of some common orthopedic issues associated with this patient population, and then I'll hand it over to Marie and Andrea, and they'll talk about wound care in general. So just to give you an outline of what we'll talk about, so I'm going to talk briefly about fractures and contractures in this patient population. Then I'll go into issues related to the hips, hip subluxation, dislocation, and then I'll finish with a discussion of scoliosis and kyphoscoliosis. So first, to cover fractures. So fractures are certainly an issue in this patient population, more common than others because of the osteopenia that's associated with patients who are sitters. So this might be due to some disease process within SMA, but we also see this in other patients who don't walk, that the lack of repetitive loading of the bone leads to osteopenia. The bone remodels in the growing child, and fractures are more common. But the good news is that bone healing tends to not actually be impaired in this patient population. So most of these fractures can be treated with casting alone, and few require surgery. But the general rule of thumb is we like to avoid long-term immobilization. So in a growing child, that means we're usually casting for less than a month. Casting for more than a month can lead to more osteopenia and then muscle wasting, and sometimes we get fractures above and below where we cast as well at these stress risers. We do treat some fractures with surgery, ambulatory patients, and sometimes sitters with long bone fractures around the hip and the femur that are difficult to cast. We can affect some early pain relief and mobilization by using surgical fixation in that population. Contractures. So contractures are common in these patients, as you know. Upper extremity contractures, usually adduction contractures of the shoulders, flexion contractures of the elbow, and occasionally the wrist. And then lower extremity contractures are also common. Hip and knee flexion contractures in the sitting position. These tend to worsen with age in sitters, and they can affect function, as we heard about in the plenary session. So most of the time we can treat these patients with good physical therapy to prevent the contractures and mobilize, but occasionally surgical release is indicated if patients have pain, or more commonly if they have an interference with sitting posture or some sort of function, and sometimes shoe wear. So what do we do to treat these? Well, typically what we're doing is tendon releases. Very rarely do we have to do more than that, like a joint capsule release. So for the hip, the tendons that we're usually targeting can be gotten percutaneously. So we're talking about percutaneous adductor tenotomies in the groin to improve hip abduction and allow for improved perineal care. And then sometimes with a hip flexion contracture, we might do a release of the psoas tendon to allow the hips to extend further. For knee flexion contractures, we can often do percutaneous lengthening of the hamstring, so the semitendinosus, or the biceps femoris tendon, which allow for more knee extensions, and then we can cast in that position. And then for ankle plantar flexion contractures that interfere with shoe wear, we'll occasionally release the Achilles tendon. So now let's get on to talk about hip instability. So hip instability is very common in this patient population, certainly more common in sitters. And the general thought of why this develops surrounds muscle weakness around the hip joint. So the growth and morphology of the proximal femur and acetabulum in a child depends upon muscle tension on the muscles that attach to the greater trochanter and the lesser trochanter, and that causes the hip to grow into normal shape. And when you have a weak patient or a patient with muscle imbalance around the hip joint, you tend to develop this characteristic deformity of coxa valga. So coxa vara is where the proximal femur approaches sort of a 90-degree angle, and then normal is that picture in the middle, and then coxa valga is on the right, where the neck shaft angle of the femur is high, above 135. And then over time, this high neck shaft angle can cause the hip to slip out laterally. And it starts to slip out typically around age 6 years. And then once you have a subluxing hip, it will typically dislocate a year or two later. Luckily, in this patient population, for the most part, historically, these hip subluxations have been found to be asymptomatic. And there's always exceptions to this rule, but the rate of symptomatology in a subluxed hip in SMA is much lower than other neuromuscular disorders. So this is a figure from a paper that was published in Journal of Pediatric Orthopedics in 2003 that had a long-term follow-up of 41 patients. And this is an adult with an asymptomatic subluxed hip. So this paper, they followed 41 patients for a mean of 18 years. They found that 21% of patients did have hip dislocations, but only 2.4% of patients had pain. And even in those patients, it was sort of hard to pin down if they were really having pain directly because of the hip or perhaps because of other positioning issues like scoliosis. So what are the principles of treatment for hip instability? So a lot of this we borrow from treatment of other neuromuscular conditions, and some of it doesn't particularly apply perfectly to SMA. So in general, as orthopedists, we're trying to maintain motion of the hip. So this is for walking and walkers, but also for seating posture and then for hygiene. We want to prevent pain. And then if there is ambulatory potential, we want to preserve that as best we can. So in other neuromuscular conditions like cerebral palsy, where we'll have spastic conditions around the hip where one muscle group might be more active than another, this often leads us to try to surgically contain the hip when it comes out. And that's because these spastic patient populations tend to have pain at much higher rates than patients with SMA. So 30 to 70%, depending on the studies, of patients with cerebral palsy and a dislocated hip will go on to have pain. So we treat these preemptively, even in asymptomatic patients. And the way we do it is we'll do osteotomies. So this is an example of where we cut the proximal femur and change the coxa valga into a coxa vera. And then we often will reduce the hip joint and then do some bone cuts around the hip socket to deepen it and stabilize the hip socket. And then these patients often end up in casts for several weeks afterwards. So this operation, we actually really rarely perform in SMA. We might do it for a symptomatic patient who had pain. But because of the natural history of hip dislocation in SMA as being pretty well defined as mostly asymptomatic, we typically don't do it prophylactically. In the 80s and 90s, some authors did advise doing this, and then later they did report higher rates of redislocation. So if you don't have the muscle strength to maintain the bony work that we do around the hip, then the hip just tends to slip out. So we typically do non-operative treatment for asymptomatic patients and operative treatment only for symptomatic patients. But the changing phenotypes associated with the advent of these new treatments that we've been discussing in this meeting are really causing us to question this therapeutic dogma. So at our meetings, pediatric orthopedists, we're wondering as a group, these young patients who receive these new therapeutics at younger ages might have better muscle tone around the hips. This might lead patients we previously thought to not have ambulatory potential to have ambulatory potential. And even if they don't have ambulatory potential, increased muscle strength around the hip joint might put them at higher risk for having pain later on. So some surgeons are advocating more aggressive treatment for containment of the hip. So the jury is definitely still out on this in our field. So now I'm going to move on to talking a little bit about spinal deformity. So we heard a bit about this in the last session as well. So scoliosis is really common in SMA. It's almost universal to some degree in traditionally classified type 2 patients or sitters. And we do have some early data out of Boston Children's Hospital and CHOP that indicates that the prevalence of scoliosis and likely hip dislocation is probably not affected by treatment with nusinersen. It still is out there. In most patients with scoliosis, it tends to occur first in adolescence, around the time of the adolescent growth spurt. But in SMA, it's probably more associated with weakness initially than it is weakness of the paraspinal muscles than it is with growth. So it's often noted earlier, prior to the adolescent growth spurt. And in terms of how this looks, on X-ray, it's typically a flexible, large C-shaped curve, like is pictured here. in most patients, but we can also have a subset of patients that have an S-type curvature. As you can see on the right there, it's often associated with kyphosis. So scoliosis is a curve in the coronal plane as the patient is facing you, and kyphosis is a curve in the sagittal plane. So these patients tend to slump forward and have a collapsing kyphosis in their chairs. Also important to note on this X-ray is the link between scoliosis and pelvic obliquity. So the pelvis is tilted up on one side and down on the other, which can affect seating balance. And then it also probably contributes to some degree to hip instability. So in this example, this patient has hip dislocation on the high side of the pelvis, which is something that we often see in patients with a lot of pelvic obliquity. So what are the consequences of progressive scoliosis? Well, we heard in the last session that gross function is affected and worsens as the curve magnitude worsens. It typically is progressive with age. It results in worsening of a restrictive lung disease picture. So these patients with high magnitude scoliosis above 50 degrees, they tend to have restrictions in their chest wall compliance that accompanies the chest wall deformity from scoliosis, and this affects their pulmonary function. And then as this curve progresses, the pelvic obliquity worsens, they have poor sitting balance, and this affects their quality of life. So how do we treat scoliosis in SMA? So this is an algorithm that was published in 2018 by McCurry et al., which there's certainly some elements of controversy, but it gives you a good idea of the general treatment decisions that we're making. So we'll start with a clinical exam, of course. If we see evidence of scoliosis, we'll get a spinal X-ray, and then the way we're measuring the magnitude of a curve is by this 2D measure, which is very common in all types of scoliosis, called the Cobb angle. So we draw a line on the most tilted vertebra down at the bottom of the curve, and then another line parallel to the most tilted vertebra at the top of the curve. And we measure, computer extends these angles out into space, and we measure the angle between the two lines. And this is called the Cobb angle. So Cobb angles of under 15 to 20 degrees, regardless of age, we will usually observe these patients, not specifically do any treatment to change the scoliosis, but we might just focus on accommodative treatments for sitting balance in the chair. And then above this threshold, and where this threshold exists is somewhat controversial, but above the maybe 15 to 35 degree range, we might consider bracing in some patients. And the goal of bracing would be to more aggressively treat sitting balance and perhaps prevent the need for surgery, or at least delay it. And then above 50 degrees, we typically are talking about surgery for this patient population. And the 50-degree threshold is somewhat borrowed from other types of scoliosis, where we know that this is where gravity causes the curve to really take off. And then we're also seeing some evidence that this might be an area where pulmonary function is really affected too. So if a patient reaches this 50-degree threshold and they're very young, they're before their growth spurt, their chest has not grown enough and their lungs are still developing, we'll often do a type of operation that allows straightening of the spine and still allows for some growth. But in mature patients, we'll do a spinal fusion, which rigidly fixes the spine in a straighter position. So talking a little bit more about bracing. So bracing, the goals are to improve sitting balance, and it is good for that, to delay surgery sometimes in a patient who's perhaps approaching skeletal maturity with a curve nearing 50 degrees. But unfortunately, it's often limited by lung function. So when we treat other types of scoliosis with a brace, we often ask patients to wear these braces for upwards of 18 hours a day. And we find that patients with SMA and patients with neuromuscular scoliosis in general have a lot of trouble tolerating brace wear for that amount of time. It can be limited by lung function. If they already have an element of restrictive lung disease, putting a hard plastic shell around their chest doesn't really do much for their chest wall compliance. Furthermore, it's controversial in this patient population because there's no really good long-term study to show that wearing a brace actually prevents the need for surgery down the line. It may delay it, and it could be have a great usefulness in that respect, but it definitely doesn't prevent the need for surgery definitively. So when the patients do need surgery, our goals are to improve sitting balance and then hopefully to slow the decline in pulmonary function, though we know that we certainly can't reverse it. So surgery for scoliosis is very common in this patient population. This is some data from a study out of the Netherlands. in 2019 tracked a population of 300 patients with scoliosis. And so we can see from this that by age 10, about half of patients with type 2 SMA have gotten scoliosis surgery. And the lifetime risk of scoliosis surgery was around 88% in sitters. So here's a couple of case studies from our patient population to show you how we think about treating these patients. So this is a 7-year-old with type 2 SMA. And you can see this kid already has quite a big scoliosis, a big pelvic obliquity, the 70-degree scoliosis associated with perhaps a 45-degree pelvic tilt there. So he was indicated for surgery, and given that he had a lot of growth remaining, we offered him a growing construct. So he had a 2-stage operation, one where we insert anchors in the thoracic spine and the low lumbar spine, and then 2, where we straighten out the spine and attach these long rods. And in this case, it's a growing construct, so we don't expose the spine in the middle. And these rods can actually lengthen over time to allow his spine to continue to grow. And this is something called a traditional growing rod, where basically there's a threaded mechanism in the middle, and we have to take the patient back to the operating room every 6 to 9 months, and we put them under anesthesia. We make a small incision, and then we loosen the screws and stretch out the spine. So this patient had this for several years, actually started taking nusinersen a couple years after the index surgery. And now you can see the rods have gotten a little bit longer, his curve's gotten a little bit bigger, but the rods have hopefully contained the spinal deformity better than it would have been otherwise. And now at this point, this patient is undergoing consideration for possibly undergoing a definitive spinal fusion, where we try to improve the correction a little bit more. But some of these patients we found don't actually need another surgery because they don't have high muscle tone. They, as long as the anchors don't fail and come apart, some of these patients can just go indefinitely with this growing construct, even though they're no longer growing. So this, in this era in SMA, is almost a historical treatment now because of the advent of a new type of growing rod that was FDA approved in 2015, 2016, or excuse me, 2014 and 15. And this is a magnetically controlled growing rod. So these are growing rods. And instead of having a manual mechanism that we have to take back to surgery and lengthen every 6 months or so, there's a little motor which is activated by a magnetic field. And we can put these rods in patients in similar techniques, and then we see them back in clinic every 3 months or so, and we can actually lengthen them by applying a magnetic field to their back while they're awake in clinic. So this has caused us to change a little bit the indications for who gets growing rod surgery and not, because the morbidity of lengthening these rods is so much lower. So here's an example of a patient who was treated with growing rods. This patient was had a bigger scoliosis at a much younger age, and he just last year ended up getting treatment with these magnetically actuated growing rods. You can see he has a bit of a stiffer curve, so the correction overall wasn't as good as I showed you with the last patient. But we see this kid now every 3 months or so in clinic, and we have a population of about 15 or 20 patients like him with growing rods, and we get to know them and their family very well, and slowly help them grow every few months. So what about more severe curves in a mature patient? Well, we're still treating these patients with spinal fusion, but our thinking on it has changed a little bit. So this is a patient of ours with a big 103-degree curve. You can see he still had a good amount of flexibility there as he was lying down and getting stretched. And this is the operation that we offered him to improve his sitting balance and hopefully slow the decline of his pulmonary function. So it's a spinal fusion, a long spinal fusion where we're going from the upper thoracic spine down to the pelvis to really stabilize the sitting balance. So what about nusinersen in this patient population? These are often patients now who are getting intrathecal treatment with nusinersen, and we have to accommodate for that. So our traditional spinal fusion creates a block of bone posteriorly, which precludes a lumbar puncture. So in this patient, you can see a little screw down there at the bottom that looks like it's sort of floating in space. And I assure you it's not. It's a marker screw in the lamina that I put in to mark a window that we made to allow for a lumbar puncture. So that's one technique. There's many other techniques to allow for continued nusinersen treatment in this patient population. Another is pictured on the right that's popularized by Mike Vitale in New York. where he does what's called a skip construct, where he doesn't expose a section of the lumbar spine, allowing for a traditional lumbar puncture. But there's also other techniques that our patients are getting that render some of this treatment perhaps unnecessary. Many of our patients are getting transforaminal injections of nusinersen, and this can be done independent of whether or not they've had a spinal fusion, because that anatomy is typically not altered. What are the outcomes of spinal fusion in this patient population? So we do a good job correcting the curve on X-ray. We can bring the Cobb angle down, but that's oftentimes just what we call, in my line of work, X-ray cosmesis. What does it really do for the patient? And so I think pelvic obliquity is probably a lot more important than our Cobb angle correction in this patient population, because it really directly correlates with their sitting balance. So if we get them better at sitting in a chair and interacting with the world from their chair, but there are some definite trade-offs for that, and a big one is really loss of flexibility. So we note this sometimes in upper extremity function. If patients are using their trunk to swing their arms into better positions, they can have loss of upper extremity function. And then also it makes hip flexion contractures more apparent. If you have a patient who has a big hip flexion contracture, they might be able to lie flat because of extension in their lumbar spine. But if we take that motion away, then some of our patients will lose the ability to lay flat after the surgery. So we really have to counsel them appropriately so they understand what they're getting into. So what about pulmonary function? So just to kind of briefly cover this, this is a developing field, but the general idea is that natural history in this patient population is a progressive decline in pulmonary function, and spinal fusion is thought to slow but not prevent that decline. So this is some data from 16 children with SMA who were surgically treated with a definitive spinal fusion. This is some older surgical techniques, but they followed these patients up for a mean of 10 years, and they found that before surgery, there was a steep decline in pulmonary function, and there was a continued decline in FEV1 and FVC in this patient population, but the decline slowed after surgery. And now we're tracking not just pulmonary function in patients, but we're doing a little bit better job of tracking health-related quality of life through patient-reported outcome measures. So this is some results from the pediatric spine study group, where we are looking at EOSC-24, which is a validated health-related quality of life measure for patients with early onset scoliosis. And we looked at this is looking at a pulmonary function subset of those surveys. So this is asking patients things like, how often are you admitted? How often do you have, for pneumonia, how often do you have shortness of breath and such? And they found that even in this patient population with that had growing rods, they had decreased FVC at 1 and 2 years post-op, but even in the face of this decreasing SVC, their quality of life, as they saw it with regards to their pulmonary function, was actually improving at 1 year and 2 year post-op. So this is a little bit confusing, and the author suggests that perhaps we should apply a little more weight to patient-reported outcome measures rather than pulmonary function, especially in this younger patient population that might have trouble participating with PFTs. So lots of unanswered questions still in this patient population. I think we're still learning about what the roles are of bracing, which patients can really stand to benefit, and how it might affect pulmonary function. And then the changing phenotypes and our changing surgical techniques are causing us to question our dogma about how and when to operate on these patients. So the tweener populations, where somebody is maybe 10 to 11 years old, and they have a couple of years of growth remaining, should we be operating on that patient with a growing construct to try to really maximize their volume, but maybe subject them to multiple surgeries, or should that patient get a definitive spinal fusion and be one and done and put the surgery behind them? Hopefully better pulmonary function and health-related quality of life data will help us answer those questions in the future. So thanks. So that's the end of the ortho session. So maybe we can pause if anybody has any questions about that, and then we'll move on to the wound care session.
Dr. Voorhees, there's a question in the chat that says, would you recommend serial hip x-rays for sitters that you may or may not anticipate ambulatory potential for?
Yeah, so in other neuromuscular populations, that's certainly a standard of care. We do surveillance hip x-rays. annually in most of our neuromuscular populations who are at risk of subluxation. That has not been the traditional recommendation in SMA because we're treating these patients more symptomatically. But I think because there's so many unknowns about the developing phenotype, I think an annual AP pelvis X-ray would be very reasonable.
The next question is there any consideration for reducing contractures, either in upper or lower extremities, now that motor function might be better preserved on treatment?
Yeah, I mean, I think that, like I said, I think for contractures, I think, physical therapy is going to be the first line of defense against all these. And I think that we certainly need to be more cognizant of how contractures might affect function in patients with improving strength. So I think that would be a much more a call for more aggressive therapy in those patient populations. I think that, the patients that we typically are treating surgically for contractures are often patients who have less strength. Because by virtue of these tendon releases, we are decreasing strength a lot. And so it's not really something that we typically apply to a very high functioning patient.
I don't see any other questions so far. Oh wait, there's another one here. How do you approach a varus foot deformity if child's not ambulating, casting versus surgery, or if the child is near losing ambulation?
Yeah, I mean, I would approach it very differently in a patient who was ambulating and having trouble than I would in a patient who's non-ambulatory. My algorithm for dealing with foot deformity is entirely dependent on ambulatory potential. So if you have a patient who's non-ambulatory who has a progressive foot deformity, then we are, when it's still flexible and correctable, we'll treat with bracing. When it gets more rigid, we can consider a trial of casting to get it back to a braceable position to try to avoid surgery. And then if we get to the point where the skin is really limiting our ability to correct something with casting, then that's where we would consider surgical correction if it's really interfering with footwear. But sometimes in the non-ambulatory patient population, we can just continue to accommodate a deformity with different shoes and different braces, and we don't necessarily need to do surgery in that patient. It's a very individual discussion that I have with each family. In an ambulatory patient, it's very different. We have different criteria for when to operate on these patients based on our understanding of gait mechanics. So we'll often do a gait lab study, which will help us understand how that patient's foot deformity affects their overall walking ability. And if that plus our clinical evaluation would indicate that a varus foot deformity is really affecting the way a child walks, then we consider surgical correction.
Thank you. I don't see any other chat questions. So if you'll stop sharing screen, we'll share ours. Great.
All right, thanks everyone for joining us, and thank you, Dr. Voorhees, for that excellent first half. We're going to now transition into wound care. My name is Marie Hamilton. I'm one of the wound ostomy nurses here at Packard, and this is my partner, Andrea, and we'll just continue. So we're going to review a number of skin issues, some unique risk factors to our SMA population, some prevention, and then offer up some treatment and management for you all. There's a number of common skin issues, but some that we'll touch on today are pressure injury, incontinence-associated dermatitis, and touch a little bit about other medical adhesive injuries and surgical adhesive. So today we're going to kind of review some risk factors that make our SMA patients vulnerable to pressure injuries. So knowing that a lot of them are wheelchair-bound, mobility becomes a high issue for pressure injuries. They have a decreased sensation, so sensory perception is another high risk factor. And because they are doing a lot of transferring or sliding up and down in bed, they're at high risk of friction and shear injuries, which are also a risk factor for developing pressure injuries. A lot of them may have incontinence or be underweight, which can play into their nutrition. And they could have tissue perfusion, oxygenation issues. And then a lot of them, as Dr. Voorhees alluded to, are in braces and have different respiratory devices that could lead to pressure injury as well. On your screen here, you see on the left, we've got some great visual with some what we would consider hotspots or primary sites that we would want to be on the lookout for pressure injuries. So bony prominences, and then of course, just doing kind of head to toe assessment. So considering the occiput, the sacrum, and then our elbows and heels. Remembering that muscular tissue is really sensitive to ischemia or hypoxemia or pressure on that site because it is a high metabolic demand area. So if there's too much pressure there for a long time, you can reduce blood flow to that area and then make it more susceptible to pressure injuries. And then muscles tend to be deeper. Muscles are deeper, and so they tend to show their injuries later. So it's important to be mindful of our patients, how they're sitting, what their position is, and then how frequently we're assessing and offloading appropriately. Our SMA patients also have a reduced ability that have that reduced sensation, so they might not be able to describe pain, which can put them at higher risk of pressure injury. And then for any patient, SMA regardless, any seated position above 30 degrees puts you at high risk for shear, and that will weaken the integrity of your skin layers, and so that puts you instantly at a higher risk of pressure injury. We have a number of foam silicone dressings that you can use for padding different devices. We've just shown a couple examples here. We also use hydrocolloids like the image on your far right with the NG tube. You can see under bracing, there's a number of methods to kind of protect the site, but being really mindful of those bony prominences. And then of course, not only respiratory devices, but things like feeding tubes and G tubes. We have a number of foams that can be helpful for not only pressure, but also wicking away moisture from the skin. You can also reach out to your occupational therapists and physical therapists. They have excellent processes for evaluating what kind of positioners are helpful and can help with wheelchair padding and the like to help prevent pressure injuries in these patients. There are also positioning things like pillows or wedges that can make sure that we're positioning our patients in a way that reduces pressure on those bony prominences. Additionally, the NPIAP, National Pressure Injury Advisory Panel, has a number of screening tools that can be helpful if you're trying to assess the risk of your SMA patients. They have different things that take into consideration, maybe things that you wouldn't think of off the top of your head, for example, nutrition or skin moisture, body temperature, things like that. And that can help you evaluate for seating appliances and then be considerate of if you're in need of a low air loss mattress, for example. So just really great resources and for evaluating risk.
Thank you, Maureen. Next, we're going to turn to conversation about moisture breakdown, which includes incontinence-related breakdown. So moisture builds up most commonly in skin folds. So our pannus folds or our axilla, necks, all those areas with a deep skin fold can develop moisture. That moisture, if left unmanaged, can develop into a fungal rash and result in breakdown with that. Another place we see a lot of moisture breakdown is around medical devices. Marie already touched on this a little bit, but the humidity with the respiratory devices and also secretions from things like trachs and G-tubes really adds to that moisture picture. And then lastly, we have the obvious urine and stool moisture in the diaper area for anyone who's incontinent and wearing a brace, and that can result in skin irritation as well. These patients with SMA with immobility, factors in immobility, it was in their skin sensation being altered, and their incontinence really increases their risk of breakdown from these. So how to manage this? There's a variety of different things you kind of want to manage based on what the specific issue you're dealing with. So if you have a fold of skin, we have moisture wicking fabric that can be placed within the fold of the skin to pull that moisture out and allow the area to dry and stay dry. You really want to cater those interventions to what the patient needs. Some patients are very moist, some patients are not very moist. So that will help you know how much additional work you need to do. Do you need to look at it every few hours or less often to help keep it clean and dry? Another thing to consider with moisture management is how many layers are around the patient. If they're wearing a brief or clothes on top and they're laying on an incontinence pad or sitting on an incontinence pad, all of those layers add heat and moisture, and that just increases the concern for moisture breakdown. You can use protective creams. We tend to recommend zinc oxide-based creams. You can get a variety of zinc oxide creams over the counter at the grocery store or through prescriptions, and those can help protect the skin. And then also, as Marie talked about, the foam dressings can be really helpful. This just shows a little bit of how to apply the moisture wicking fabric. It can be used creatively around tubes, in folds, in a variety of areas. And then a little bit about rashes. So the picture in the bottom left corner, the two pictures, the one on the left shows what we would consider to be a pretty classic fungal rash. You can see red dots that kind of extend away from the reddest part of the wound, and those red dots become little satellite lesions. You see them extending further and further. Those satellite lesions are just very classic fungal rash characteristic, and often those rashes are associated with a lot of itching. So if you have a patient with that sort of an experience, you really want an antifungal treatment. Anything over the counter can help, but then there's also a variety of prescription options. We tend to favor antifungal powders over creams because we want to keep the area dry. And then the picture of those two pictures, the one on the right shows kind of what we see with incontinence breakdown, incontinence-associated dermatitis. And you see more denuded skin where the top layer of skin is coming off and much closer to the anus. That's a more classic diaper rash experience. And again, those you want to use a barrier cream. You want to try to protect the skin as best as you can with those barrier creams. Often zinc oxide is the best option. And then lastly, if you have a rash or a skin problem that is not being resolved with the treatment that you've started, then you definitely want to reach out to dermatology or other professionals because there may be a different process happening.
And we're also going to touch on here some skin breakdown from adhesives. So a lot of times they're defined as medical adhesive related skin injury or MARSIs. Typically, this is associated with the removal of the adhesive or how tight it was on the skin. If the patient's having any swelling, it can affect how that adhesive is laying on the skin. And then also, some of our patients have developed allergies to adhesives, which can look really angry and be a cause for concern. So our SMA patients, they do have that kind of decreased sensation. So again, just being really mindful of what they may not be able to express, but what they may be feeling, and then being really cautious on how we're removing these items. So the following slide, we're going to just show you here, there's a variety of ways that can improve adhesive removal. So there's a spray version, there are wipes, but you want to be mindful not only of the product that you're using to assist you to remove it, but also how you're removing it. So you'll see in the center picture there, it's showing a pull and stretch out technique with Tegaderm. Oftentimes our inclination is to pull the Tegaderm up towards the sky, but you want to consider pulling kind of down and out and stretching that off the skin to help lift it, especially if they're very hairy. It's a way to prevent a free wax. So keep that in mind. And then also we want to be mindful of other skin protectants. So just if we know of a patient who might be more vulnerable to moisture, there's a variety of skin protectants on the market out there. And then considering allergies. So what are we using to clean the skin? What are we using to take off? And what are we using to protect? So if you see on the bottom two photos, we have a patient who reacted to a Tegaderm-based dressing change for the central line. On the left there, you see it's getting really scaly and peely. But then on the right, you can see the improvement. And the change was we changed our cleansing agent. So we went from a CHG to an iodine-based clean, and then also from a Tegaderm-based adhesive to a cloth tape-based adhesive, which the patient's skin really appreciated. So just being mindful of the products that you're using, what are you using to protect, and how are you removing products.
The last thing we're going to just really briefly talk about is surgical complications. Dr. Voorhees talked about a variety of surgical interventions that may be available for these patients. And we did find in the literature there is some evidence that patients with SMA have an increased risk of this wound healing disorder or surgical complications. And that can result in things like infection of the wound. You can get a pressure injury because of having the surgery and then being less mobile after surgery because of pain issues or different restrictions. You can actually develop fistulas that come up through the wound to the skin and kind of leave a tract in the skin and can drain and be a long-term problem. And these issues can actually, if they develop further, result in hardware removal, which is obviously the thing that we are trying to avoid. So really what you want to do to avoid these surgical complications is manage nutrition as best as you can. That's preoperatively and postoperatively, optimizing their nutrition going into the surgery, and then allowing for increased calorie and protein intake after the surgery to allow for wound healing. Additionally, maintaining the wound or the incision in an area free from pressure is really helpful. So if they have a spinal fusion, you don't want to position them on their back, directly on their back as much as you can. There are going to be times when they're on their back, but side-to-side positioning can be more helpful. If they have a tendon release, but they wear a brace, you want to make sure the brace doesn't touch the incision of the tendon release. So thinking about those things, and then lastly, thinking about moisture like we talked about. You want to make sure that incontinence doesn't, so if they are incontinent and they get a spinal fusion, that you're managing their diapers closely so that the urine and stool doesn't go back onto their incision, because that'll break down the incision, and just keeping them clean and dry in general. So that is the presentation we have. So we can move to questions. We have a question here. Is the safe and simple no-sting skin barrier film chemically similar to Cavalon no-sting skin barrier? How does it compare, and are there potential side effects? That is a great question. They are very, very similar. Basically, all the skin barrier films out there are pretty similar in properties and can be used interchangeably. Most of them shouldn't be used in neonates under the age of 1 month. I don't see any other questions yet.
So I think Dr. Day had a question. He mentioned, you mentioned nutritional elements for postoperative wound repair. Are there any nutritional guidelines for preventing pressure sores?
That's a great question. You really want to optimize protein. Protein's going to help build healthy skin, and you want to optimize micronutrients. So looking at maybe drawing labs and finding out if zinc or vitamin C are low, those two really go into wound healing and building healthy skin. And then every once in a while, you can have some amino acid deficiencies. So if a patient has frequent breakdown, that would be a deeper dive that you may want to look at. But generally, protein and calories, especially in a postoperative setting or even in a time of having increased pressure injuries, that is not the time to be losing weight, because that'll increase your risk of pressure injuries. Good question.
So I have a question. What about you mentioned so many different products, or so many different products in wound care, and how what is the rate of these patients getting these things covered by insurance versus buying these things out of pocket? Patients always ask me about this, if it's helpful for them to have a prescription for all these barriers or not.
Yeah, great question. A lot of times insurance is resistant to cover something that is available over the counter. But if we can show a medical necessity and give reason to say, if we provide this product for them, it'll decrease hospitalizations, it'll decrease these other issues, then sometimes we can get the products covered. It is helpful because especially with the barrier creams, you can use so much of them that it can get costly. And so really working closely with the nurses in the clinic or the case managers, whoever are helping with outpatient supplies, and also the providers to offer that medical necessity need. We write those pretty frequently as wound care nurses to describe, if we don't use this product, then they get this pressure injury, which has been shown over time, and then they're back in the hospital. So it's cheaper for the insurance company to cover the product. Another question, does osteoporosis limit orthopedic approaches in SMA? Is there a role for bisphosphonate?
Yeah, that's a great question. In other patient populations that are at risk for frequent fractures, in pediatric orthopedics, the big one is osteogenesis imperfecta. Bisphosphonates have been heavily studied to see if they decrease fracture frequency, and the general thinking is that they may. And so, in patients who are gaining a new functional level, that might certainly be a consideration. But the other thing is that the differences in this patient population versus osteogenesis imperfecta, if they gain function, their muscles start working better, they start walking more, then they're probably going to have better bone density just as a result of that. There are cases where I've had a patient who's been particularly osteopenic who I am planning on doing a spinal fusion on, that I will refer to endocrinology for consideration of bisphosphonate treatment prior to surgery, because it can affect the rate of complication. So some of the complications of these surgery relate to anchor pullout from screws and hooks falling out of weak bone. So if it can be strengthened a bit with bisphosphonates beforehand, that might help.
I don't see any other questions as of now.
I can go back. Actually, I had another comment to make about the question. Just saw the question in the chat about a varus foot deformity in a walking versus a sitting patient. One thing I didn't touch on was sort of the patient who is about to lose ambulatory potential. This is a tough thing when you have a patient who is walking, has a developing deformity, and then they're nearing the loss of ambulatory potential because of weakness. This is a patient population where we are very hesitant to be aggressive surgically, because we can make the foot look straight and beautiful and have a great cosmetic result. But then if the patient doesn't have the capacity to rehab after that operation, we might sort of push them over the edge into not walking again. So we're very hesitant to do aggressive surgeries that require mobilization in that setting.
I have a question for Dr. Voorhees. Thank you for both presentations. They were great. For those patients that have their sitters, but they do use the standard, it's unclear yet whether they will develop walking or not based on the current treatments, and they do have hip dislocation. Would you consider nowadays surgery for those, even if they don't complain of any pain?
Yeah, I mean, this is certainly an area of controversy in the field. Some of my colleagues are being very aggressive in that setting and are treating these patients just like we do for a cerebral palsy patient. And so a cerebral palsy patient who is in that category, who is able to stand with a stander, we will put that hip back in and treat it in the manner that I described. I think that the short answer is I really don't know, and none of us does, because it really depends on that patient's trajectory. But I think that if the patient has shown that they are standing and that they have the muscle function around the hip to maintain a standing position, then I think it's totally reasonable to consider surgical treatment. But I think, it's such a big operation that without the long-term follow-up to make the case to the family, I think it would be sort of more of a shared decision-making thing that I would discuss with the family, and acknowledge that, the field just doesn't have the long-term follow-up to really make the best informed decision.
Thank you.
Because the other thing is, if you have a patient who is able to stand, but they're a marginal stander, if I do a large operation that, reconstructs their hip and then put them in a spica cast for 6 weeks, they might not have the ability to stand like they did before that, just from the surgical hit and the muscle weakness that the recovery involves.
Thank you.